Kishore, and you have Dr. Okay. A very good evening to all the doctors who have joined us today. It is a pleasure a pleasure to see you all, and thank you so much for joining us today on a Saturday evening. It's a weekend, I understand, but I think the panel which we have got for you is really compelling. So I welcome everybody to the International Symposium on Heart Failure, where we are going to focus especially on Emperor Preserve, which we, as we all know, is the first and only successful trial in the HFpEF patients. And today we have, of course, an authority in heart failure who needs no introduction. We have Dr. Milton Packer today with us from Baylor University, and we all know that he is the director of the entire Emperor program, and he is going to actually present to us the key findings of the Emperor Preserve trial. And of course, we have eminent cardiologists from, of course, our homeland India today to aid and get more insights and make this session more meaningful. So today's session is going to get moderated by Dr. Brian Pinto sir, who of course we all know is the HOD and cardiologist from the Holy Family Hospital, Mumbai. And along with it, we have co-panelist Dr. Ashwini Mehta sir, who is, of course, a senior consultant cardiologist at Sri Gangaram Hospital, and Dr. Jay Gopal B, who is director HOD and a senior intervention cardiologist at Lakshmi Hospital, Palakkad, Kerala. So with this short introduction, I would not keep all of you away from a very interesting session which we have ahead. And I would request Dr. Brian Pinto to just set up the context of this meeting, and thereby hand over the session to Dr. Milton Packer. Thank you.
Thank you so much. Thank you for introducing us. I think the slides are with you for me to set the context for the meeting, Kishore. And, I would, it'd be a great pleasure for us to hear Professor Milton Packer tell us something about heart failure with preserved ejection fraction. But before we go there, I would just like to set a little bit of the context for this meeting. I think all of us have spoken so frequently about heart failure with reduced ejection fraction that it is extremely exciting and fascinating for me to be talking today about heart failure with preserved ejection fraction, because really some time back, I think we didn't even understand this term. And there are three areas which I would now say to you: ejection fraction less than 40%, then the ejection fraction between 40 and 49. Now, that really confuses me a lot, because the European Society made this the HFmREF, and I was there when they coined this term, and it sort of confused me, because then it told me that this was another group of patients, and ultimately you came out with those who had an ejection fraction of more than 50%. And I would say that I would like to coin this term of HFpEF as an ejection fraction of more than 55%, because I think then we separate these three entities. And I would like to say that this middle entity is one that has caused the maximum confusion. And I would like Professor Milton Packer's view on this. We also have the heart failure with improved ejection fraction. The improved ejection fraction patients with HFrEF who have come to us, been treated initially with ACE inhibitors, beta blockers, now with sacubitril, valsartan, and SGLT2s, and whose ejection fractions have now come to 45%. And what do we call them? Do we call them with improved ejection fraction? Do we call them reduced ejection fraction that is still there in that range below 55%? How do we kind of classify them? This is an area which we really need to know. Second slide, please. So phenotypically, if you look at the heterogeneity that you see in HFpEF, is something that really sets this whole thing apart, I think. For example, you look at an obese patient, you look at somebody who has hypertension and diabetes, you look at somebody who has atrial fibrillation, you look at somebody who has elevated blood pressure, you look at ischemic heart disease, you look at obesity, sarcopenia, aging, deconditioning, and I would tell you that how would one size fit all? How does a single drug really optimize itself to treat all these entities. And that's why I think that we have so far failed in whatever trials we have conducted so far until we have come to Emperor Preserve. Because here you can see phenotypes which are so different. For example, I had a 100-year-old lady who came to me with a little bit of gastroenteritis. And then I did for her a situation where I gave her IV fluids. And when I gave her IV fluids, she went into heart failure that was so significant that she couldn't, 5 minutes. She could not even get into any situation. So that was when I got into a situation where I thought that I am now dealing with a patient who has a normal ejection fraction, going into heart failure with 150 ml of fluid. What am I dealing with? Is this is preserved ejection fraction? Is this aging that is causing this problem? What is causing this problem? Next slide, please. And so if you look at the various varieties, you would see the garden variety of HFpEF, which you see patients who are obese, hypertensive. You would see those patients who have right heart failure, CAD patients, AFib patients, hypertrophic cardiomyopathy type of patients, high output heart failure, valvular heart disease, and the rare causes of HFpEF. So all these form a different group of patients. All of these form a different group of patients that we need to tackle. And therefore, we have a different set that we can see at all these particular periods of time. Next slide, please. And here you can see, and this is what I want to bring out to the fore, is the fact that the Trivandrum Heart Failure Registry, the one from Kerala, showed us that the mortality keeps increasing with these HFpEF patients. Please understand that when you see a HFpEF patient, this patient may have a mortality even in excess of the HFrEF patients, because I think the HFrEF patients have so many modalities and drugs available to them that the HFpEF patients don't have. So you will actually see mortalities in excess of what you see in the, and look at this, the Trivandrum Heart Registry. The Trivandrum Heart Registry also showed us that unlike the Caucasian registries and the Caucasian groups of patients, that we had about 30% of our patients who were HFpEF patients among the heart failure patient that we had. I'm not saying this is for all over the country, but at least in Kerala, it was shown that 30% of the patients were HFpEF patients. You can see the mortality going up with time, 3-year mortality in excess of 40%. This is what the scenario is. And then I think I have my last slide from the Trivandrum. Next slide, please. And here you can see that when your patients get hospitalized, whether they be HFrEF patients or they be HFpEF patients, you can see that when there are multiple hospital admissions or even more than one hospital readmission, mortality is much higher, both for the HFpEF and the HFrEF patients. And here I will stop and then ask Professor Milton Packer to take it up from here and tell us about Emperor Preserve and how we are going to treat our HFpEF patients in future. Over to you, Professor.
Thank you so much. I think I need to shift to my own slides, and let me see if I can do that. Can you see my slides?
Not yet, sir. Not yet.
Let's make sure. Can you see them now?
No, sir. No, we can't.
Okay. I think it's because I am not controlling the screen. Can you give me control?
You are, sir. So there's a green button right at the bottom. So we have given you access to share the slides.
Do you see my slides now?
No, sir.
Okay, hold on one second.
Yeah.
Let's try a different approach. Hold on one second.
So I can give you a shortcut.
No, I'm fine.
Perfect.
I just need to do this again.
Yeah.
Can you see my slides now?
Yes. Yes.
Okay.
Very well.
Fantastic. One needed an extra step. It's no problem. Anyway, thank you so much. I'm delighted to be here with everyone today, and I want to make sure that I am telling you a complete story. And that complete story is about the Emperor program, not just the Emperor Preserve trial. The Emperor program was a program of two trials, almost identical trials, with SGLT2 inhibition with empagliflozin. Both trials enrolled patients with heart failure. One trial enrolled patients with an ejection fraction of 40% or less, that was Emperor reduced. And the other trial enrolled patients with ejection fraction of greater than 40%, and that was Emperor preserved. And in order to understand Emperor preserved, one first has to understand Emperor reduced. So let's talk about Emperor reduced first. And I presented the results of this trial a year ago at the European Society of Cardiology meetings, and it was published simultaneously in the New England Journal of Medicine. And we have been publishing a great deal on Emperor reduced for the last year. So the background of Emperor reduced is interesting. There have been about 8 large-scale clinical trials, not in heart failure, but in diabetes, chronic kidney disease, and that have shown that SGLT2 inhibition reduces heart failure hospitalizations. I want to emphasize that that is a signal that came not from heart failure trials, but primarily from trials of diabetes in which patients were enrolled who did not have heart failure. So in these trials, the SGLT2 inhibitors prevented heart failure hospitalizations in patients who did not have heart failure. So we were interested, and our good friends in the DAPA-HF trial were interested in seeing if these drugs would treat heart failure in patients who already had heart failure. First trial to show that was the DAPA-HF trial led by my very good friend, John McMurray, and it showed a reduction in the composite of cardiovascular death and worsening heart failure of about 25%. We then, at the same time, were conducting the Emperor reduced trial. It was very similar to DAPA-HF, except the patients were sicker. The patients had worse ejection fractions, higher levels of natriuretic peptides. Most patients had ejection fraction of 30% or less, and they were randomized double-blind to either placebo or empagliflozin 10 milligrams daily, in addition to their usual therapy. The trial had 3 pre-specified endpoints: primary endpoint of the composite of cardiovascular death or heart failure hospitalization, first secondary endpoint, total first and recurrent heart failure hospitalizations. There was also a second secondary endpoint, a slope of decline glomerular filtration rate over time. In Emperor reduced, we randomized 3,730 patients. 1863 to empagliflozin, 1867 to placebo. Excellent follow-up in all of these patients. Average duration of treatment, about 16 months. Here are the baseline characteristics of Emperor reduced. I am showing them to you side by side with the baseline characteristics in the DAPA-HF trial, which studied dapagliflozin. And you can see ejection. We had lower ejection fractions, higher natriuretic peptides, worse renal function, and about 20% of our patients were receiving sacubitril/valsartan, a neprilysin inhibitor. So we had a meaningful number of patients already receiving sacubitril/valsartan. Here's the primary endpoint of the trial. This is cardiovascular death or hospitalization for heart failure, 25% reduction in risk, highly statistically significant. The effect was driven primarily by a reduction in hospitalizations for heart failure, 31% reduction in risk. We did not see a reduction in cardiovascular death. And this is exactly the same pattern as has been seen in trials of type 2 diabetes, primarily reduction in heart failure hospitalizations, not a reduction in cardiovascular death. Here are the subgroups in the trial, very consistent effects in most patients. I want to highlight the top subgroup, which is the presence or absence of diabetes. And regardless of whether a patient had diabetes or not, the benefit was exactly the same. Didn't matter. Glucose, baseline glucose did not matter. Non-diabetics responded just like diabetics. All of the other baseline characteristics had no influence. And look at the bottom of this slide. This is the subgroup based on the baseline use of sacubitril/valsartan. We found a significant effect of empagliflozin even in patients who were getting a neprilysin inhibitor at baseline. So the effects of this drug are additive to sacubitril/valsartan. They're additive to spironolactone or eplerenone. They're additive to beta blockade. So all of the foundational drugs in heart failure exert independent effects to change the natural history of the disease. The benefits of empagliflozin were seen early. Statistical significance in this trial was achieved only after 12 days after randomization. So a very early effect. The curves separate within days. It's an impressive finding, but I would like to emphasize we have seen this same separation of curves with sacubitril/valsartan and with beta blockers and with spironolactone and eplerenone. So here is our second secondary endpoint. This is total hospitalizations for heart failure, first and recurrent events, highly statistically significant reduction with empagliflozin. Here's our third endpoint that was pre-specified, the difference in EGFR slope, and there was a flattening of the slope with empagliflozin. Empagliflozin reduced the rate of decline of EGFR over a period of 16 months. But what was really, I think, impressive here was the effect on renal outcomes. This is the composite renal endpoint, 50% reduction in renal events with empagliflozin. The renal events here is a 40% decline in EGFR, EGFR below 10 to 15, or the use of dialysis or other renal replacement therapy. So we achieved success on all three endpoints that were pre-specified. We also found some really other interesting benefits. When we looked at the type of hospitalization that was reduced by this drug, this is a graph showing total hospitalizations requiring intravenous vasopressor or positive inotropic drugs. very meaningful reduction with empagliflozin compared with placebo. We found a 33% reduction in total hospitalizations requiring admission to intensive care. And we not only found a benefit of empagliflozin on hospitalizations, but we found a benefit of empagliflozin on health status, on functional capacity, on symptoms. Here's a graph showing the effects on New York Heart Functional Class. The top panel shows the odds of improvement. The bottom panel shows the odds of deterioration. And you can see a greater likelihood, 30%, a range of 20 to 40% greater likelihood of improvement with empagliflozin and a 20 to 40% lower likelihood of deterioration with empagliflozin in New York Heart Functional Class. So all of these were very exciting. And but all of these were seen in patients with ejection fractions of 40% or less. At the same time, we were carrying out a trial in patients with ejection fractions of greater than 40%. The same protocol, the same case report form, the same committee, the same adjudication rules, the investigative sites. The only difference between the two trials, ejection fraction 40% or less in one trial, ejection fraction greater than 40% in the other trial. And so in this trial, the design was exactly the same as in Emperor Reduced, except the patients had heart failure with a preserved ejection fraction. 5,988 patients randomized to empagliflozin or placebo. Here, the average follow-up is longer, 26 months rather than 16 months. The endpoints are the same. And I'm going to focus on the primary endpoint and on the first secondary endpoint, because these are the heart failure outcomes. So 5,988 patients randomized, 2,997 to empagliflozin, 2,991 to placebo. Excellent follow-up, just like in Emperor Reduced. Here are the baseline characteristics. And these baseline characteristics are so typical of HFpEF in clinical practice. About half the patients were women, half the patients had diabetes, half the patients had chronic kidney disease. And look at the background medications. The investigators were treating these patients as if they had heart failure with a reduced ejection fraction. They were getting inhibitors of the renin-angiotensin system. They were getting spironolactone, eplerenone, beta blockers. The only drug not well represented in the Emperor Preserved trial was sacubitril/valsartan, only used in 2% of patients. So other than that, this is a group of patients that is so similar to that seen in every other HFpEF trial and most physicians see in clinical practice. So here's the primary endpoint of the trial: 21% reduction in risk of cardiovascular death or heart failure hospitalization, highly statistically significant. And if you look at how early the effect was, you remember that in Emperor Reduced, the statistical significance was seen at day 12. Well, in this trial, we saw exactly the same pattern: early statistical significance. Statistical significance here achieved at day 18. So a very early effect of these drugs to reduce the primary endpoint, particularly hospitalizations for heart failure. And I want to emphasize that. The primary endpoint was cardiovascular death or heart failure hospitalization, but the primary benefit was on heart failure hospitalizations, a 29% reduction in risk of heart failure hospitalizations, no significant effect on cardiovascular death. So if these results look familiar to you, it is because they are almost exactly the same results as what I showed you for Emperor reduced. So the two trials had very superimposable results on heart failure outcomes. And again, a primary, about a 30% reduction in heart failure hospitalizations. Here is the first secondary endpoint, total heart failure hospitalizations, 27% reduction in risk. Now, because the effect was driven primarily by heart failure hospitalizations, if we look at cardiovascular hospitalizations, at all hospitalizations, of course, the effect size gets smaller and smaller because now we're adding to the analysis hospitalizations which are not influenced by empagliflozin. They're not increased, they're not decreased, it's a neutral effect. So this slide really shows that this is a specific effect on heart failure events. That's the primary benefit of these drugs. The type of hospitalization that was prevented by empagliflozin was a serious hospitalization. Here, and I showed you this for Emperor reduced, here are the hospitalizations requiring intensive care. 29% reduction in risk with empagliflozin compared with placebo. Here's the effect on total hospitalizations requiring intravenous vasopressor or positive inotropic agents. 27% reduction in risk with empagliflozin. Here are the effects on health status using the Kansas City cardiomyopathy questionnaire. We found benefits on this in Emperor reduced. We found benefits on this in Emperor preserved. This is actually the first trial to show, first large-scale trial to show benefits on health status of any drug in patients with HFpEF. There have been positive signals in other trials, but we were very, very happy to see this. And again, I showed you the data on New York Heart Class. And there, I showed you exactly this type of slide for Emperor reduced. I'm showing you now the same analysis for Emperor preserved. And again, 20 to 40% higher likelihood of improvement, 20-30% lower likelihood of deterioration. And on New York Heart Class, sustained over the first year of therapy, and with statistical significance appearing at 12 weeks. Remember, for hospitalizations of heart failure, we were getting statistical significance at 18 days. So what's really nice about Emperor Preserved is that it's the first HFpEF trial which shows a clinically important and very clear and statistically unequivocal favorable effect on the primary outcome. There have been other HFpEF trials, and they have shown some benefits, but those benefits have been small. And the level of statistical significance has not been persuasive. There was a 13% reduction in risk with neprilysin inhibition in Paragon. There was a 10-15% reduction in risk with candesartan in charm preserve. There was a 18% reduction in risk in TopCat in the Americas. All of these were very encouraging, but they were not very compelling. And Emperor Preserved really did produce a compelling result. 21% reduction in risk with a statistically persuasive p-value. Now, here I'm putting the results of Emperor Reduced and Emperor Preserved side by side. And you can see on the primary endpoint, very similar results. Time to first hospitalization, similar results. Time to cardiovascular death, similar results. Total heart failure hospitalizations, similar results. And you look at this and you say, you know, ejection fraction doesn't matter. For this drug, it doesn't matter if the ejection fraction is 32 or 55. It doesn't matter whether it's 21 or 47. And that is really interesting because we have these classifications of heart failure. As you've already heard, we have traditionally called patients HFrEF, HFmrEF, HFpEF, all based on ejection fractions, and yet the patients are being treated in a similar way in the community. And here in the Emperor program, the patients look like they largely responded in the same way. You might conclude from this that ejection fraction doesn't matter. Well, it gets more interesting than that. Here is a pre-specified analysis of the influence of ejection fraction in Emperor Preserved. Now, what is shown on this slide is total hospitalizations for heart failure. Remember, that is the primary benefit of empagliflozin. And here you can see the influence of baseline ejection fraction. Patients 40 to 50%, 50 to 60%, or greater than 60%. And the effect of empagliflozin to reduce heart failure hospitalization, statistically significant, 0.57 in patients between 40 and 50, statistically significant, 0.66 between 50 and 60, but no effect in patients with ejection fractions of 60 or greater. The P trend here is 0.008. Now, we have seen this attenuation at the highest ejection fractions in other HFpEF trials, in 3 other HFpEF trials. I'm going to show you one of them. This is Paragon. I was on the executive committee for Paragon, and you can see that as ejection fractions increased in Paragon from the low 40s to the highest ranges of ejection fraction, the effect size got smaller and smaller. And so we decided we would superimpose the results of Emperor Preserved onto these results with Paragon HF. And here is that analysis which we recently published in Circulation. Paragon is shown in blue. Emperor Preserved is shown in red. And you can see between the low 40s and the low 60s, the effect of empagliflozin in Emperor Preserved was about twice what we saw with sacubitril valsartan versus valsartan in the Paragon HF trial. And so between 40, in the low 40s to the low 60s, a greater effect of SGLT2 inhibition than neprilysin inhibition. But when you get to the highest ejection fractions, 62, 65 or greater, there is no effect, no benefit of either drug. Primarily when we look at heart failure hospitalizations. Now, we really looked at this in a very granular way. And when we looked at this in a granular way, and here we're looking at heart failure hospitalizations, either time to event or total heart failure hospitalizations, you can see we're doing cut points here at ejection fractions ending in 5. And so when we go from patients with ejection fractions of less than 25% to less than 65%, we're getting a very consistent treatment effect, about the same magnitude, a 30% reduction in risk. And we're seeing this across emperor reduced and emperor preserved. But when we get to patients with an ejection fraction of 65% or greater, then we lose that effect. There's an attenuation of effect at patients with ejection fractions of 65% or greater. And so we've seen this now in so many HFpEF trials. And it's really, really interesting to think about this. In the Paragon trial, they reported that we observed that sex mattered. Women responded better than men. And that was true regardless of ejection fraction. Well, when we looked at the influence of sex in emperor preserved, no difference. Men and women responded in the same way. Very consistent benefit up to 64%, and then attenuation of the effect at 65% or greater. Now, who are these patients who have an ejection fraction of 65% or greater? We see them in every single trial. We saw them in TopCat, we saw them in Emperor Preserve, we saw it in Paragon. And so let's take a look at the baseline characteristics of the patients with ejection fractions of 65% or greater, and compare them to the patients all the way at the other end of the spectrum. And when we do that, we see something really interesting. This group of patients with ejection fractions of 65% or greater are primarily consist of elderly women. They're hypertensive. They do not have markedly elevated levels of natriuretic peptides, very low incidence of ischemic heart disease, high incidence of atrial fibrillation, but their natriuretic peptides are not elevated despite the high incidence of atrial fibrillation. I and many others think that these patients may have shortness of breath from their atrial fibrillation and not shortness of breath due to heart failure. So in any case, the most important point here is that if a patient has heart failure, and it really doesn't matter what their ejection fraction is in most cases, the results of emperor reduced and emperor preserved look exactly the same when you put them side by side. This is really, really gratifying. It gives us a treatment which we really need for patients, and it also challenges our basic assumption about whether ejection fraction should be used to classify patients with heart failure. I'm really delighted to be with you today, and I'm really looking forward to hearing your questions and having a great discussion. Thank you so much.
Dr. Pinto? Thank you, Professor Packer, for a very enlightening session. Is Dr. Pinto around? And so I think we've really learned quite a lot from this particular trial. And of course, it's gratifying to see that, the first time in the history that we had a trial where, for heart failure with preserved ejection fraction, there was a substantial benefit. No other drug had really shown this kind of a benefit in preserved ejection fraction. Now, I have a few doubts which wanted to clarify. When you say that the patients, so if you categorize them by the ejection fraction, let's say 60% or more, they do not have any benefit. That's what we have seen from this. So is this the category of heart failure with a normal ejection fraction, some proposed new nomenclature? I don't know.
So it's a wonderful question. So we think that the cut point for ejection fraction, which is now 40% between reduced and preserved, we think it should be moved. We think it should be moved to 60 or 65%. Now, here's the thing which is so interesting. If you do that, right now, at least in the United States, about half the patients that are being hospitalized for heart failure, about half have ejection fractions that are less than 40, half have ejection fractions more than 40. If you move the cut point to 60 to 65%, then 85% of the patients, 90% of the patients have ejection fractions of less than 60 to 65. So it makes the treatment of heart failure much easier. And we can now focus on who are these patients at the highest ejection fraction. But we can also have great confidence that when we have patients, most patients with heart failure, we don't have to worry about ejection fraction in how we treat them.
But the other interesting thing is that, when you take the trial in total, about 49 to 50% had atrial fibrillation, the entire group. So you've shown that those patients with the normal ejection fraction more than 60, predominant were elderly females with atrial fibrillation. So, but then in a lesser ejection fraction, the AF did not show any difference. So, are we seeing seeing a different phenotype who would respond better? And I was also looking at the data. About close to about 890 or so was the mean, the pro-BNP levels in this category of patients. But overall, if you look at the trial design, also I think the baseline inclusion was not really looked into the NT-proBNP. It was 300, and with AF it was 900, right?
So so that you have picked up on something really important. If you had atrial fibrillation, in order to get into Emperor Preserved, you needed an N-terminal proBNP of greater than 900, So in the patients with ejection fractions of 65%, you just said their average N-terminal proBNP was below 900, and half of them had atrial fibrillation. So a lot of these patients were entering the trial with an N-terminal proBNPs that just qualified for the study, just made it. And that raises an interesting question whether these patients really have HFpEF. Do they have shortness of breath from heart failure? Do they have shortness of breath from atrial fibrillation? Do they have shortness of breath from some other condition that is seen in elderly hypertensive women? These are really important questions. We're very excited about this because the reason we're excited, we're not the first people to see this subgroup. Every other trial has seen this subgroup. So this subgroup is quite real. Now the question is, we really have to understand these patients. We really have to understand them. And the way I think we're going to understand them, is we have to give them a name. We have to give them their separate classification.
And also, don't you think that, when you have the RNA data with the Paragon trial and all that, the lower the ejection fraction, the better the benefit for this class of patients. So even in this HFpEF, 40 to 50 had much better benefit than the above 50 group. So why is it so?
No, you're 100% right. The ejection fraction has, you saw that with Emperor Preserve, the effect of ejection fraction, there was no effect of ejection fraction from very low numbers up to 64. But with sacubitril valsartan, there is a much greater influence of ejection fraction. The patients with ejection fractions less than 40% have a greater effect than those between 40 and 55, very little effect in patients over 60, 65. So the slope of the ejection fraction relationship is steeper for sacubitril valsartan. And the other thing, which is really important, is sex matters for sacubitril valsartan and doesn't matter for empagliflozin.
Dr. Brian Pinto, Dr. Ashwini.
Professor Packer, just want to know from you that situations where patients have ejection fraction above 55%, should we be giving them empagliflozin, thinking that we will get some benefit from them?
Well, did you say over 55 or over
over 55%? Who have
50 people with ejection fractions of 55 to 64% have a 30% reduction in the risk of heart failure hospitalization. So absolutely, patients with over 55 should get the drug. The other thing, which is really, of course, important, is that we all have to realize that ejection fraction is a very variable biomarker. When you repeat the ejection fraction, you rarely get the same number, even on the same test. And so this group of patients with ejection fractions of 65% or greater, they are a comparatively small group of individuals. They're really, really interesting. But from a clinical practice point of view, right now we would use empagliflozin in a similar way, whether patients had HFrEF or HFpEF.
Right. Is there anything that you'll look in the ventricle, for example, concentric small ventricle versus suppose you had a patient 85 years old who was in HFpEF, and had a small contracted ventricle pumping away at 60%, the patient went into HFpEF and had failure. Would you be using empagliflozin in this patient?
Well, remember one thing that one needs to do in a patient with a smallish ventricle, especially one that is thickened, is one has to rule out amyloid. It is really, really important. It's not that frequent. We see it in about 10 to 15% of patients who have HFpEF. But it's a very important exclusionary diagnosis.
So would you say that all of these patients of HFpEF, or maybe those who have small ventricles, would need to have an MRI done?
Well, the way that one diagnoses amyloid, at least the way we diagnose it, is on a pyrophosphate scan.
Okay.
So that's our gold standard for cardiac amyloid. Fortunately, at least in the United States, pyrophosphate scans are much easier, are much more available than cardiac MRIs. Cardiac MRIs in the United States are still relatively confined to specialized centers.
Okay. So how do you all do cardiac MRIs in your HFpEF patients, in your HFrEF, which group of HFrEF patients? Do you do cardiac MRIs in certain groups of patients where you want to decide about fibrosis? Where do you all put your patients for cardiac MRI, and how do you use cardiac MRI in your situation?
It's a really great question. And so we like getting cardiac MRIs because the precision of the test is really very nice. There are measurements that we can get on cardiac MRI that we can get on echo, but they're much more clear, concise. We can get much better assessments of volume. As you have said, you can quantify fibrosis. There are specialized measurements that you can get on cardiac MRI. So you can get a much better framing on pathophysiology. But in terms of decision-making, clinical decision-making, I don't know if cardiac MRI influences our judgment about treatment very much. And the exception is make sure the patient doesn't have amyloid.
Yeah.
Dr. Parker, can I ask you a question?
Yes.
Well, as a routine, over the last few years, we've been doing cardiac MRIs in all patients of heart failure, whether it's HFrEF and HFpEF. And it's really surprising to find that many times, many of the patients are having sarcoidosis and many other reversible causes. And in fact, many of the patients who've been labeled as the basket cases or, being referred for the transplant, we have seen them turn around dramatically. And interestingly, in India, we have had two patients from our center and one of them who underwent a cardiac transplant, and we found him to be having tuberculosis. And then we found another very interesting patient, which we could diagnose tuberculosis on a cardiac MRI. And then we got the FNAC done and we could prove it. So I think cardiac MRI is really helping us all across the spectrum. Well, I have another question for you, sir. And the question is, you very nicely pointed out, and I do think that after this results of Emperor Preserved, probably the way we are treating heart failure, there is a lot of homogeneity which is coming about beta blockers, the ARNIs, and all that. Do you think, sir, that with the results of Paragon, which we had improvements with the ARNI in the mid-range of HFpEF, you think that it would be wiser to use ARNI in the latest between 50 and 60% also?
So I remember in heart failure with a reduced ejection fraction, we use foundational four drugs, okay? So sacubitril valsartan, beta blocker, mineralocorticoid receptor antagonist, and a SGLT2 inhibitor. We do not choose one above the other. We say we need four. And my prediction is we're not there yet, but in a year from now, we will be saying that we have to use 3 drugs in HFpEF. We have to use an MRA, we have to use sacubitril valsartan, we have to use an SGLT2 inhibitor. It will not be one or the other. We will be using multiple drugs in HFpEF, just like we use multiple drugs in HFrEF. The only difference is we don't have any data with beta blockers in HFpEF. None, really, no data with beta blockers. But you can see in Emperor Preserved, over 80% of patients are already getting a beta blocker. So here's the thing which is so interesting and so important. The more and more you look at it, the more and more the treatment of HFrEF and the treatment of HFpEF becomes similar. And you use multiple agents in one, multiple agents for another. The most important thing, I think, is we have to make the ejection fraction cut point of 40%. we have to make that disappear because it has no meaning.
Yeah, thank you so much. I have another question for you.
Sure.
Well, I've diagnosed patients with amyloidosis and endomyocardial biopsy proven, and fortunately, they turned out to be treatable ones. And they've had wonderful recovery. In fact, 2 patients. And I'd like to ask you that now they're doing pretty well with the therapies for amyloidosis. Do we treat them as HFpEF and give them empagliflozin? This is a question.
This is a wonderful question. This
Yeah.
is a fantastic question. So I have asked this question of a dear friend, Dr. Matthew Maurer, who led the trials in cardiac amyloidosis. He's a wonderful physician, and I'm very, very biased because he was one of my trainees. So I'm very, very personally fond of him, and I have asked him this question, and he believes that when you give a cardiac amyloidosis and you give them an amyloid-specific drug, you should also give them other drugs for HFpEF because he thinks that they benefit. And as you know, we did not exclude cardiac amyloid in Emperor Preserved, but we just don't know who the patients with cardiac amyloid were because we made no attempt to identify them. But I think the answer to your question is yes.
So I think that brings us to another, it's just a continuing question. In fact, this I had in mind. Now, you have a patient with what we call as a heart failure with recovered ejection fraction. So somebody has had a reduced ejection fraction. It's not the amyloid I'm talking about. And completely recovers, and his ejection fraction touches something like 55, 60. And we also know that, you have treated them with ARNI, beta blockers, MRA, they've done well. And you have data now saying that you discontinue these drugs, they go back to
we actually have data. There's actually been a trial, a wonderful trial from the UK, where they took patients with improved ejection fraction, patients who really had dramatic responses, and they had dramatic responses sustained for a year or more. And they randomized them to either continue their treatment or stop their treatment. And when they stopped their treatment, they got worse.
So that category of patients, do you think it's wiser to put them on EMPA? And again, a similar question, you have a patient with a CRT, a cardiac resynchronization therapy was improved, normal ejection fraction from a reduced ejection fraction. Does that patient merit empagliflozin?
Well, the first of your 2 questions I was very comfortable with, and that is that I think that every patient who has ever had heart failure with a reduced ejection fraction, with one exception, and I want to tell you what that exception is. Every patient who has ever had HFrEF should be on 4 foundational drugs indefinitely. Now, here's the exception. The exception is the acute phase of myocardial infarction. When you see a low ejection fraction and it's a hibernating myocardium, and if 2 months later the ejection fraction is normal, that is not a patient who ever really had HFrEF. That is a patient who had infarction-related hibernating myocardium who recovered. That's a different recovery than the recovery of heart failure with improved ejection fraction. So you see what the distinction that I'm making.
Right. So I'm just going back to the trial on Emperor reduced. So if you were to compare this with the DAPA HF trial, see the difference, you had sicker patients in Emperor reduced, but there was no mortality benefit in that trial, whereas DAPA HF had a mortality benefit.
Yes.
So likewise in this Preserve trial, it's true that the heart failure hospitalizations have remarkably improved. I mean, in the trial. But
Yes.
then what about mortality? So
No effect on mortality. So now you're at the most important trial that we're looking forward to now is a trial called Deliver. It's a trial of the dapagliflozin in HFpEF. And I will tell you, we're going to know the results of that trial in January, I think. So not far from now, like 4 months, 5 months. My prediction is they are going to show results in HFpEF, which are identical to what we showed in HFpEF. And they will not show a mortality benefit. And remember, in the SGLT2 inhibitor trials in diabetes, there was a heart failure hospitalization, but not really a mortality benefit. Really, only one of the diabetes trials had a cardiovascular mortality benefit. That happened to be with empagliflozin. So the mortality benefit with these drugs is very unpredictable. The heart failure hospitalization benefit with these drugs is remarkable. It's extremely consistent across trials and across disease states.
And another interesting thing is about the decline in GFR. You know, it was, by definition, it is a 40% fall. You know, they've just looked into, and vis-a-vis a 50%. There's a lot of controversy on that. So
it's a wonderful controversy. Yes. So let me say this: we specified 40%. If I had to do it all over again, I would have used 50 or 57. And the reason is when you use a 40% threshold, you get more events, but you don't actually answer the question of a treatment effect. So you get more power, but you get more events that are unrelated and unaffected by treatment. So if I, in the future, when I get an opportunity to define a renal event, a renal outcome, my threshold will be a sustained 50 or 57% reduction in EGFR, not 40%. Did I answer your question?
Yeah, thank you. And just one more question. Do you think 25 milligram of EMPA would do better? It's intuitive to think about it that way. 10 milligram has worked wonders, and why not 25?
So remember, we have one trial called EMPA-REG Outcome. It was in diabetes, where they randomized people. It was 3 arms: placebo, 10 milligrams, 25 milligrams. 10 and 25 milligrams, exactly the same effect on everything. No difference. And this was an outcome trial. So I see no reason to use a dose of empagliflozin that is higher than 10 milligrams. There's no evidence that you will get a greater benefit. And even for glucose lowering, the benefits at 25 are really tiny compared to 10. But for outcomes, no difference between 10 and 25. So one of the great advantages of SGLT2 inhibitors is there's no dose titration. Starting dose is the final dose.
Thank you. Dr. Ashwini, you're muted. You're muted, Dr. Ashwini.
Sorry. Well, I like to ask you another question. I like to take you away from empagliflozin, Professor.
No problem.
So I like to bring your attention to the Soloist trial. And there, you had again evidence that the SGLT2 inhibitors work in HFpEF. Do you think that this is more of a class effect, not tested with the other SGLT2 inhibitors, or you think it's just specific to empagliflozin? We're going to have the dapagliflozin result as well recently.
Yeah, I think this is very unlikely to be specific to empagliflozin. I think this is going to be a class effect, but two points, which is very important. First is Soloist had very few patients with HFpEF. They found an effect, but the confidence intervals of that effect were extremely wide because the number of patients and the number of events was small. As you know, it wasn't a very big trial and it was ended early. I see no evidence that SGLT1 plus 2 inhibition is better than SGLT2 inhibition for heart failure outcomes. However, as you know, there are data that suggest that sotagliflozin may be better on stroke and myocardial infarction, but that's different. That's a different outcome. 3, which is the point I really sort of would emphasize the most. I really don't like using the word class effect because I don't know what it means. I think that whenever someone asks me about class effect, I am certain that their definition of a class effect and my definition of a class effect are not the same. But I hate to ask them what their definition of a class effect is. So does a class effect mean that the effect is present in more than one member? Or does a class effect mean it is present in every member? So I'll ask you a question. Ready? We will have fun.
Yeah.
Is there a class effect of beta blockers in heart failure?
No, not at all. I would not agree.
No, right. Yeah. Exactly.
Absolutely, I get it. Yeah.
Right. So, but there is more than one beta blocker that has a benefit, but
True.
Not all beta blockers have a benefit. So, every time someone asks me about a class effect, I really want to ask them, what do you mean? What is a class effect? And we just need to probably not use the term, but at least show the data. And if we show the data, we're in a good place. And then everyone will be happy.
Yeah, I would like to, Professor Packer, I would like to ask you another question. This is actually moving a little away into the phenotypes of heart failure with preserved ejection fraction. I remember having read an article where you have 3 phenotypes, and the phenotype P3. This was in Journal of American College of Cardiology a year ago. So that's a group where obese, hypertensive patients who have a little higher natriuretic peptides, and they respond very well to aldactone, your spironolactone. So do you think that, like the TopCat trial, the people from the eastern part of the country, like Russia and all that, they had low BNP levels, they did not respond well, whereas the American counterpart responded well. So the phenotype of obese, hypertensive, high natriuretic peptides, and who respond to the mineralocorticoid receptor antagonists would probably respond better to DAPA.
God, so many interesting points. I mean, you have raised so many. One can talk about your question for 15 minutes and have a wonderful time. Let me try the following. Ready? Let me try.
Right.
First is, I am personally convinced that the patients in TopCat enrolled in Russia and Georgia did not have heart failure. It is not that they had a different form of HFpEF. They didn't have heart failure at all. When the records were gone back and examined, there was really no evidence of heart failure. There was also very little evidence that patients actually were given their randomized drug. So there are enormous quality issues in Russia and Georgia, and I think we need to basically take all of those data and set them aside. The second point is among patients who respond to spironolactone, is there a group of them that respond better? And the answer is in HFrEF, we think so. We think so. The patients who respond the best to mineralocorticoid receptor antagonists are those who have visceral adiposity. They're either obese, they have increased waist circumference, they really have, they make enormous amounts of aldosterone, and they respond beautifully to spironolactone. However, we don't know whether that is true in HFpEF. And the reason is that almost all patients in the Americas who were enrolled in the TopCat trial were obese. So we don't have a non-obese group to compare them to in TopCat. So that is a difficulty. Also remember, and I'm giving you maybe too many answers to each of your questions, but please remember that when people are obese with HFpEF, they typically have lower levels of natriuretic peptides, not higher levels of natriuretic peptides, because adipocytes clear natriuretic peptides and lower them artificially. So obese patients have lower levels of natriuretic peptides for any given level of left ventricular filling pressure.
Thank you. Really, really great to hear that. So
I think, we have really had a wonderful time, with Professor Packer, but we can't leave him just like that. I would ask him that in atrial fibrillation patients with CKD, patients with atrial fibrillation, patients who have so many different kinds of phenotypes, you have taken and given them this one drug, and then you say that it has worked. So, I somehow believe that this could not be this is difficult to understand, that one drug will fit all. You have phenotypes that go from obesity to thin patients, to patients with pulmonary hypertension, to patients with atrial fibrillation, to patients who have adiposity versus patients. So how do you explain that, Professor Packer? What do you think
remember,
is the...
remember something which is really, really important, and I showed a slide about this. Empagliflozin is not a treatment for HFpEF. It is a treatment for the heart failure of HFpEF. So it is not a treatment for the atrial fibrillation of HFpEF. It's not a treatment for the chronic kidney disease of HFpEF. It's not a treatment for the lung disease. It's not a treatment for all of their comorbidities. It is a treatment for the heart failure of HFpEF. For that, is a very effective treatment. But patients with HFpEF have so many other conditions, and those conditions result in a great deal of morbidity. Remember, heart failure hospitalizations accounted for only 17% of all hospitalizations in the Emperor Preserve trial. So we are treating one component of a multi-system disease. These patients have many other diseases. However, for the treatment of heart failure, empagliflozin's effects are homogeneous across most of the subgroups.
I think, Professor Packer, you've given us real insight in.
I cannot hear. I cannot hear you, so I don't know if there's a problem with the technical aspects or something else.
And just one more question. What
Sure.
about this discontinuation rate? Quite high, about 23%.
Yes, and that's pretty typical of HFpEF trials. So remember, it's the comorbidities that are coming in, and when they get exacerbated, physicians, investigators don't know if it's the underlying disease or the drug, so they tend to stop it. Remember that the discontinuation rate was the same in placebo as in empagliflozin. So it's not the drug that drives the discontinuation. It's the disease that drives the discontinuation.
So they recommend in red, if you look at the right-hand side, early screening the therapy.
Ashni, you want to make some comment?
Of the dose to maximum recommended doses offered.
In fact, hello.
Yeah, we can hear you. Please go
Am I
ahead.
audible?
Yeah, clear.
Yeah. So, in fact, I'd like to ask one question to Professor Packer. That we've had number of trials which have failed, and this is for the first time we have a clear-cut trial which seems to be working in HFpEF. Do you think this has finally answered all our questions with that, with the HFpEF therapy, and this is the number one choice?
This is the beginning.
Hmm.
This is not the end.
Okay.
This is the beginning. So let me explain. For years, we've been doing HFpEF trials, and we've been getting a little depressed. We've been getting discouraged. So when you get a positive trial, your natural response is encouragement. Encouragement to do more. Encouragement to ask more questions. Encouragement to look for new treatments. Is this the end? Oh, no. This is the beginning. But before this trial, we really didn't have a beginning. So one of the advantages of this trial is now we have a beginning we didn't have before.
Okay. So another question I'd like to ask you. When you treat heart failure in most of the patients now, and now we know that whenever heart failure, as of now, whether it's HFpEF, HFrEF, we want all of them to be on board right in the beginning. But still, a patient with a borderline hemodynamics and all that, each one has its own choice, either of ACE, ARB, beta blockers. Do you think today it's one of the first drug to be used, the SGLT2, irrespective of the type of heart failure?
So you may have seen a paper that John McMurray and I wrote in Circulation in December. So I need to give you a little bit of background to this paper. John McMurray and I have been doing clinical trials together for 30 years. And in most cases, we were involved in the same trial. We were on the same committee for the same trial. In the case of SGLT2 inhibitors, we separated. He led the dapagliflozin trials and I led the empagliflozin trials, but we were still best friends. We were doing sister trials, so-called competing trials, but we were not competing with each other. We were asking the same question with two different drugs in two different trials. So when the trials came out, we decided that it was time to join forces and to propose a new algorithm for the treatment of HFrEF. This is before Emperor Preserved. And we said the sequencing of drugs that we currently use, ACE inhibitors, then a beta blocker, then an MRA, then a switch to sacubitril valsartan, then an SGLT2 inhibitor. It makes no sense. And then not only does it make no sense, but it takes 6 to 9 months, and that's time wasted. So we proposed an algorithm of 4 drugs in 4 weeks. 4 drugs in 4 weeks. And our beginning part of that algorithm was a combination of a beta blocker and an SGLT2 inhibitor. But remember, 4 drugs in 4 weeks means even if you start with a beta blocker and SGLT2 inhibitor, 2 weeks later, you're on sacubitril valsartan. There is no such thing as first-line therapy in heart failure. There are multiple first-line therapies in heart failure. You can use them in any order, in any sequence that you want, but you need to use them. If you don't use them, the sequence doesn't matter. And if you do use them, the sequence doesn't matter. Is that helpful?
Yeah, that's quite helpful. So another one question I'd like to ask you. If you think we had quite a large number of patients in this trial with amyloidosis, we did not separate it, in fact, the amyloidosis patients with the other HFpEF. You think results could have been a little different or more favorable? Or it's a speculative question. Well, if the amyloidosis, why this was not taken out right at the beginning? It was not thought of, or maybe in hindsight?
So remember, this trial was designed in 2016.
Okay.
And screening for amyloidosis at that time was not routine.
True.
Second is we wrote in the protocol that patients with known cardiac amyloid should not be enrolled.
Absolutely.
But we did not say you needed a pyrophosphate scan in every single patient to rule out cardiac amyloid. So I will tell you that I believe that 10 to 20% of the patients in EMPEROR-Preserve probably had cardiac amyloidosis. We don't know who they are. So it is impossible to know whether the effect of the drug was less in those people, the same, greater. I would like to think that empagliflozin is not a very specific treatment for a cardiac amyloid, and therefore, had we taken it out, the effect size would have been larger.
Maybe.
But I can't prove that to you.
Well, in fact, I contributed about 36 patients to this trial.
Yes.
And didn't look for amyloidosis in any one of them.
Right.
At all. Yeah. So in fact, we do not do this scan so frequently in our country. It's not easily available. But we do diagnose amyloid through other means and only have the index of suspicion high when the patients have proteinuria, maybe microalbuminuria and other manifestations. Otherwise, we are not really looking for amyloid in our country. Well, the question regarding the class effect, I just go back to that. The reason I asked you, because in India, we have quite a lot of molecules which are available, which are, off patent kind of a thing, the generic molecules. And we have a molecule by the name remogliflozin, which is an SGLT2 inhibitor. And we are quite price-sensitive country. And a large number of our patients would not tolerate, would not be able to tolerate the medication because of the cost issues, and they are not able to take it. So that was keeping in mind, we have no evidence as far as that, but looking at the evidence from what all trials we have, whether it's Vertus CV, Soloist and all that, if a patient cannot afford any of this, would you think picking up any of the SGLT2 inhibitors, if the patient is diabetic, would be okay? Other than the
I think it's okay if the patient's diabetic or non-diabetic.
Yeah.
Let me say this. If the alternative is no treatment,
true, The alternative is no SGLT2. Yeah.
If you're telling me the alternative is no SGLT2, this is
True.
a really easy question.
Absolutely.
It's unbelievably easy. The most important thing is most countries in the world, when it comes to medical care, are price sensitive. Some countries are more price sensitive. I live in a very strange country where we say that price matters, but we act like price does not matter. And the reason is because behind us, people just print money. And since they can print as much money as they want, then, you can afford anything. But I am not certain whether our current situation is going to last very long. So when you say that India is price sensitive, ask me that question again in 10 years. And I predict that the US is going to be very price sensitive in 10 years from now.
So just one final question to you, sir. I think a very enlightening session. What about hypertrophic cardiomyopathy? I read some papers where SGLT2 inhibitors could perhaps be the future for hypertrophic cardiomyopathy, heart failure.
I would love to know those papers. I know of no clinical trial.
So it's just a few this thing which was presented in European heart failure meeting. So some preliminary.
I would be very, very surprised if SGLT2 inhibitors work for hypertrophic cardiomyopathy. I would be very surprised. As you know, there are drugs which are being developed. One is approved in the United States for hypertrophic cardiomyopathy. They inhibit contractility. They really do work. They're very good. They are particularly effective for obstructive forms of hypertrophic cardiomyopathy. I should add, in the United States, they're very expensive. And so I did want to add that. But I would not. I really have no evidence or confidence that SGLT2 inhibitors are going to be an approach for hypertrophic cardiomyopathy. But if someone does the trial and shows that there is an effect, obviously we would all pay attention to that.
Thank you, sir. Thank you for a very enlightening session. We really loved it.
Thank you so much. Thank you.
Thank you.
This has been wonderful. I must tell you, I do a lot of these conferences. This question and answer period has been the best.
Thank you so much. Thank you.
Thank you so much. Thank you.
You have asked unbelievably wonderful questions. I have enjoyed the question and answer period 10 times more than I enjoyed giving the talk.
Thank you. Thank you. So kind of you. Thank you.
Thank you. And we've really been enlightened by your talk and the way you've given answers. You've clarified most of our doubts.
Well, if I clarified all of your doubts, you would not invite me back.
Absolutely.
So, thank you so much once again for that enlightening session. Really, really loved it. Thank you.
Thank you.
Thank you.
Bye-bye.
Thank you so much. Thank you so much, Dr. Packer. Thank you so much, Dr. Ashwini Mehta, sir, and Dr. Jayagopal, sir, and Dr. Brian Kimball, sir, if you're there. Thank you so much. It was really an enlightening session indeed. I'd like to formally close